All right, can you guys hear me?
Yes.
Okay, perfect. So welcome, everyone. This is a new group of students. It's a new year, and it's really exciting. My name is Brian Cott. I'm a clinical associate professor here at Robert Wood. We have an exciting evening. We have some great speakers. But I will say we are a little bit out of order this year because usually we do an intro. We have a resident speak first, and then we get into a little more specifics of the different types of people and different types of experiences. So we're leading off with probably what was, one of our best, if not our best seminar last year, where we talked about women in orthopedics. And I think it's a great way to start. It's interesting that I see a lot of females, first-year students, and last year we had both females and males listening in just because I think they caught the bug after our first one or two. So hopefully the guys will join us later on, and hopefully they'll listen to this recording. But in any event, I wanted to formally welcome you to the Department of Orthopedic Surgeon at Robert Wood Johnson. Many of you are probably completely unsure of what you want to study and what you want to do here in medical school, but we want to introduce you to the department as early as possible. We want to get you connected, and we want to let you explore the field early in your medical school years if this is something you want to do, and you'll learn a lot more about why we think it's important to expose people early. But just to start out, what is this group? And it's the Orthopedic Interest Group. You've probably heard about it from your friends. You've probably heard about it from some of the second-year students. But I wanted to just say really quickly what the mission statement and the values of this organization are. And there's going to be plenty of programming throughout the year, but it all comes back to what our mission statement and our values are. Now, again, talking about what I said before, students must identify specialties of interest early on their training. It becomes important later on for residency, and then they need to gain experience in those specialties to see if they really fit in and this is something they want to pursue. So we have kind of a four-pronged mission here, and that's provide exposure to orthopedic subspecialties and career trajectories, create opportunities for hands-on learning, foster an environment of intra and intergroup inclusivity, and establish longitudinal mentorship relationships. And we're going to do that, and throughout the year, there's going to be lectures and panels. There's going to be workshops. There's shadowing opportunities in both the clinic and the operating room. There'll be social events such as a tailgate later this year. And we hope to build connections both amongst the medical students and residents. And the three values we chose that were most important to us were education, the inclusiveness, and mentorship. And just the leadership, I know you've gotten some emails from them, but I want to publicly recognize all the work they've done. If you saw our Google Drive and the stuff that's been happening this year, it's really incredible. We've put together a lot of great things. So hopefully we can share our subspecialty with you. And that's Ali, Jalika, Julie, and Aman, who have worked tirelessly for this. And then the attending leaders, Dr. Charles Gatt, who's the chairman of the department, and you'll hear him speak next week if you're tuning in. Dr. Tom McPartland, who has been integral to working with the medical students and really shepherding them through the whole process over the last 10 to 15 years. Dr. Stephen Adelson, another pediatric orthopedist, and myself. So with that, I want to turn it over to the ORIG board, who can introduce our speakers tonight. It's going to be a great evening, and I'm really looking forward to it. So thank you and welcome.
Thank you so much for the introduction, Dr. Cott. So my name is Jalika. Like Dr. Cott mentioned, I'm one of the ORIG e-board members this year. So we have 4 wonderful panelists joining today for our Women in Orthopedics panel. So I just wanted to go ahead and introduce them. So first we have Dr. Antonia Chen. She's the Director of Research and Arthroplasty Services at Brigham and Women's. She's also an Associate Professor of Orthopedic Surgery at Harvard Medical School. So Dr. Chen, if you could just wave your hand so everyone can see where you are. Perfect. Okay, so next we have Dr. Kathleen Beebe. She's an orthopedic surgeon at University Hospital Newark, and an associate professor of orthopedics at Rutgers, New Jersey Medical School. Dr. Beebe, if you could just wave your hand as well. Awesome. Okay, next we have Dr. Julianne Forlizzi. She's an orthopedic sports medicine specialist. She has expertise in shoulder, knee, hip, and ankle procedures, and she's with Ortho, Connecticut. She might be joining in a little late, but Dr. Forlizzi, if you're on the call, just let us know. And lastly, we have Dr. Rachel Sotksy. She's an assistant professor of orthopedic surgery at Johns Hopkins. Awesome. So thank you all for being here today. We're so excited. Like Dr. Kopp mentioned, this is one of our bigger events of the fall. So we are excited to have you here. And we also wanted to share with students on the call that these are also mainly alumni from Robert Wood Johnson as well. So we're going to just start off with some of the questions that the students submitted ahead of today's event. Feel free to ask questions in the chat. You can also ask us privately and we can repeat your questions if you're not comfortable sharing them with the group. And we can go ahead and get started. So Julie and I will just be switching off asking questions. Alrighty, so for the first question, what was a formative experience in your decision to pursue orthopedic surgery or your subspecialty within orthopedics?
So I can break the ice if that's the case. So for me, it was actually being a Robert Wood Johnson student. First year of medical school, when we were learning hand anatomy. I don't know if Rachel got this or not when I was there, when we were there, because we wouldn't start off the same, right? It was actually taught by a hand surgeon. So most of the times it was mostly by the PhD group and they're fantastic. But a hand surgeon came on and taught us about the hand. So I thought that was really neat. I hadn't even thought about orthopedics. My sister had her ACL reconstructed and I'm old. So there was a VHS tape. And after the VH test, they're like, do you want to see it? And I go, no, I'm not interested in surgery. I want to do pediatrics. But I saw the anatomy and I saw people immediately getting better. So I got to do some research with Dr. Alfred Tria, who's no longer there, but he was a joint surgeon at St. Peter's. And I got to work with him and I got to see patients go from not walking to walking. And those were the two probably most formative experiences for me to say, you know what, I want to do ortho for the rest of my life.
So I wasn't as quick as Dr. Chen with my love of the hand teaching, but we did get taught by Dr. Firestone, who's no longer there. He was a hand surgeon who taught us anatomy, but I got into my rotations. I actually came to medical school just like Antonia and said I was going to peds and never going to be an orthopedic surgeon, and was thrown into an orthopedic surgery elective during my surgery rotation because all the other electives were full, and I was thrown out of anesthesia because it was full with fourth year rotators. And I went into ortho, and the first day did a total hip with Dr. Freed, who's no longer there, and said after that day I was going to be an orthopedic surgeon, and then somehow became a trauma surgeon from doing my AO basic and in my intern year.
I started out a little bit earlier than some of that. I was a physical therapist before I went to medical school and worked at Sloan Kettering at that time. So I had a lot of exposure to rehabilitation of patients who had had surgery and reconstruction for malignancies. And then ultimately, when I went to medical school, those were kind of the areas where I was most interested in continuing with orthopedics, but also with oncology. And also had a lot of interest in peds. So ended up, going into a subspecialty where I really got to marry my love of all those things, pediatrics, oncology, and orthopedics all together.
All right, so our next question is, what does a typical week in your life look like between operative volume, clinic hours, teaching, education, and other personal, either academic commitments or family commitments?
I can start with that. So, well, my life has just changed. I have a 2-month-old that's downstairs probably screaming, but I'm an ortho trauma surgeon, so my week is busy, especially at Hopkins, where I'm at the second busy trauma center in the state of Maryland. So I operate anywhere from 3 to 5 to even 7 days a week. Then I'm in the clinic once a week, usually an admin day. But again, before I even went out, we were very busy. So my partner and I were both actually running ortho trauma rooms, probably do about, she just finished her board collection and did 400 cases in 6 months. So we probably do about 800 cases a year, each of us. So it's pretty busy. Day starts usually at 7 o'clock in the morning with running the boards of all the fractures, and then it goes until it goes. You know, usually typically the trauma surgeons are taking anywhere from 7 to 9 calls a month. So, and during busy trauma season, I've been known to sleep in my office because I have 15 minutes before I go into the next case, because they're pretty good about letting me flip into a different room. So I run multiple rooms at times, and at night they'll flip me into another room so we can just keep going and get things done. So it's a little bit busier, I think, than the elective practices, but we get stuff done.
And that's why I didn't choose trauma. Not that trauma is a bad thing. So trauma is cool because you're all over the body. I can't live like that. So I joke, I do right hips and left hips and right knees and left knees and primaries and revision, and that's it. I do still take trauma call, but our trauma call is not frequent. You know, I take it probably once a month. So it's not 1 to 2 times a month, weekday and weekend. So it's really not bad in comparison to what Rachel does. My split is a little bit different. So I do 2 days of research, 2 days of clinical, 2 days of clinic, 2 days of OR, and then 1 day of research. And research can vary between having a research day where I pack it with a lot of meetings all day, or on the flip side of things, I travel for work as well too. So there's a combination of research meetings, as well as industry meetings, as in addition to other, you know, teaching or proctoring or mentoring sort of opportunities. So, you know, it's either Monday and Wednesday tends to be my clinic days, and then Tuesday and Thursday tend to be my operating days. I go to 4 different sites, so that gets a little bit confusing at some points in time. I have to look at my calendar each time to know which I'm going to that day, because it does vary from week to week. It's not the same Monday through Thursday, but it's a big change, I think, in healthcare, is where we go to meet where our patients are, and we don't go to just one centralized hospital anymore at all times. So that's kind of my division of labor.
I'm also not a traumatologist, but still have to do trauma. And I spend a lot of time trying to figure out how to get off the call schedule. So I much prefer the elective practice of being able to sort of plan out my surgeries, you know, template, figure out what implants I'm going to need, you know, spend some time, you're really going through the options with patients, rather than sort of the rush of something's coming in the door now to figure out exactly what to do with it. So that's not really my strong suit. And then I spend, you know, 2 days in the office, 2 days in the OR, like another day admin. And then there's some days where some weeks where you don't have as many cases, and some weeks where you do have as many cases. And I think that's one of the real challenges in sort of figuring out which week you're going to be busy and which week you're not, and really being able to sort of squeeze things in when you have a little bit more free time. But definitely making time to sort of prioritize time for myself, time with my family, and time to do things outside of orthopedics.
I'm sorry.
And just because I'm a trauma surgeon doesn't mean there's not time.
Yeah.
Still run marathons, and now have a
Excellent.
adulting to run marathons with a 2-year-old or
In
2-month-old.
between cases, right?
In between cases. Actually, my partner has, so we actually have the only female ortho trauma service at Hopkins Bayview.
Wow.
And she put a bike in her office. So we have a bike that between cases we can dictate and ride the bike.
Nice.
Whew.
Add a treadmill and you're all set.
Perfect.
Just as a follow-up to that, I was wondering if you could talk a little bit about your current practice models and maybe how that's differed throughout your career, and maybe some of the pluses and minuses of, you know, for those of you that are working in academic hospitals versus private practice. That'd be great.
So I guess I may have been the only person who's changed. So I started out in private practice and then switched over to the academic model. So I've been at Hopkins for 3 years, but I did 5 years of private practice up in Northern Jersey. And it was a little bit too much for me. So as Dr. Chen was saying, she goes to multiple hospitals. So I was up in Northern Jersey. I was covering 5 hospitals, often multiple hospitals each night. Without a PA or a resident. So I was going into the ER, reducing things. I was driving probably anywhere from 200 to 500 miles a week between hospitals. So I kind of, it wasn't what I wanted to do. I wanted to work with residents. So now I'm in an academic model where I'm at one hospital operating on one set of trauma patients with residents and PAs and get the joy of teaching them. So much happier.
So similarly, I started in private practice actually, but it's Privatedemics. So Rothman Institute, which is right around the corner from a lot of you guys, is something you guys are familiar with. So the practice model is that you work with residents, fellows, and med students from Jefferson. So it was academic flavor, but in a private practice setting. And coming up here to Brigham is truly an academic model, which is good and bad, mostly inefficiency. But it was actually, interestingly enough, we're not going to delve too deep into the weeds of this because it's probably not relevant to your more in practice, but had a very similar, for lack of a better term, compensation model. That's what I had in private practice. The expectation was, you eat what you kill and you develop that. So it's one of those things where in both models, I was expected to work hard and do a bunch of cases. And on the flip side of things, also generate research as well too. So it was actually very similar in both ways, just different settings.
And I don't know anything except academics, and I definitely could not do the job without the residents. I rely on them to make the day more fun, first of all, and to bring sort of their younger skill set to the operating room. So sometimes that means they just, did suprapatellar nailing with the trauma team, and I didn't learn that in residency. So they bring that to the table. So I really enjoy that. A lot of times they help me just get through figuring out how to use the EMR. And, they really, I think, help bridge the gap and help with continuity of care, because there's always one of them there overnight. And I think that helps a lot with patient care, but also sort of with the balance of work and home life. But with that comes, sort of the slower timetable and getting through cases, and frustration of thinking like, didn't I teach this resident this already, but realizing it's a different resident and no, you haven't taught them that already. So but I think that the trade-off for me has been really great. I can't imagine doing it any other way.
So for the residents and for the students here, I would like to say we'd like to call it Groundhog Day. So we see it happen over and over and over again. So the best thing you can do as a student is learn from either your previous students, right? Or know your anatomy. That's always the biggest thing I always give as advice is, if you're at M1 or M2, you're probably going to know the most about anatomy at that point in time. By the time you go to M3, M4, you'll know probably a little bit more about orthopedics, depending on when you pick up orthopedics. So we see Groundhog Day repeat over again. And if you make it less of a repetition, it's a win in our book.
But then if you come into my OR, I want to know the anatomy, but I play music trivia with you. So my residents are quite awful at it. And it's classic rock and 90s grunge. So they're really bad, but somehow I got teacher of the year for quizzing them on stuff, because you got to know about life too in my OR, because you're going to be spending lots of time with me as a trauma surgeon at 2 a.m, and we have to have fun.
Yep, I'd fail.
All right, we want to just open it up to everyone on the call. If you want to ask any questions, just go ahead and unmute yourself.
Hi, my name is Al, one of the e-board members. I had a question about building a research mentor-mentee relationship. What would you say is the best way to go about that, and what do you expect from a mentee?
I can answer that from my standpoint. There's been a lot of different changes sort of over the years, and I think what's worked best for me is when students email me about research opportunities, that really kind of gets lost in the sauce. But I do say, if you're an M1 or 4, and we get emails also from undergraduates, so I won't speak to that, but if you've already got an ID in the medical school, I'm like, just come on over to my clinic. I'm there every Thursday, put your white coat on, blend in, and just see what orthopedics is about a little bit. And then once I see you there 2 or 3 more times, then I'm a little bit more comfortable saying, okay, well, now you're committed to the game. And let's talk about what your research interests are. So, or if you're not interested in orthopedic oncology, then go to the hand clinic and meet those guys. But I think it's really hard and challenging to sort of develop a research mentor, relationship via email with somebody that you just don't know, because we really do have a lot of students that are just emailing on a daily basis. So that's really what works for me. Just show up to the clinic, get to know us, and then we can take it from there.
Yeah, I'll echo that. It's one of those things where one, from a perspective of seeing a lot of different students, we don't want someone necessarily to work with us just for the sake of working with us, if that makes sense, right? So it's one of those things is we understand that in order to apply to residency, you likely need a research project. And so it's understandable you approach someone, but you want to approach people who, for a particular reason. For example, I do a little work. I look at periprosthetic joint infection. That's my area of interest, as terrible as that is. So you come to me, you say, I'm interested in looking up, outcomes after periprosthetic joint infections. Here's some thought processes. I'd love to sit down with you and discuss potential research ideas, right? That's something that might be really useful, coming in with a angle that you want to say, as opposed to just saying, I want to do research, tell me what to do. It's one of those things where you don't have to know how to do research, because that's what we teach you. But to be vested in the game is something that we want, because it takes a lot of effort on both of our parts to get a project over to finish line, right? And I want to see that you're willing to get it over to finish line, able to commit to getting over to finish line, and what the factors are driving you that way.
And I'll just echo the same thing as both Dr. Chen and Dr. Beebe. It's, we want to make sure you're going to get a project, you're vested in the project. So we want to see your face. We want to know who you are, because at the end of the day, when you do the research, we can write you, if we know who you are, we can write you your letter of recommendation. And that holds more value than someone who's seen you for a month or not ever, and just knows that you go to the institution and they know your name.
Great, thank you for all the advice. And then I have a more specific question for Dr. Chen, because you're a big orthoplasty doc, and I'm really interested in hip and knee surgery. Also, congrats on being the first woman inducted into the Hip Society. That's an amazing feat.
Did your homework, nice.
Over the summer, I was working on some periprosthetic fracture research, and I just wanted to get your opinion on what you would use to treat a B2 fracture. Are you more of a modular stem, or are you a monoblock titanium tapered fluted stem?
You're definitely giving an orthoplastic surgeon when you're asking questions like that. I don't think my residents ask me questions like that. So well done. You've already stumbled onto the best subspecialty. I will personally say that because I can. Going from patients to not walk and walk again. So it's one of those things where for B2 fractures, I'm a big modular fan. And the only reason I'm a big modular fan is what we are mostly in our work is our training, right? So in my training, I only use modular stem. I probably only use a monoblock stem once or twice in my training. And so because of that, we always say that you shouldn't use this phrase, but we use this phrase all the time. But in my hands, I'm more comfortable, or I'm better with, or I know the system better with modular stem. So I'm a modular stem kind of person, but I think the older surgeons will tend to be monoblock, and the pendulum is swinging back the other way, actually. Similarly in residency, and I don't know, but the other people here in residency, we rarely cemented stems when it came to hips. And now the pendulum's swinging the other direction. And our trauma colleagues, I see Rachel smiling, are cementing more on hips, right? So these
always
are
cement.
Yeah, these are all important skill sets to pick up. That's why as students, as residents, as fellows, try to get into as many cases as possible, because you might see something that you don't commonly see. And then you can see, like, you might do 100 modular stems, but someone's doing a monoblock stem, go join them, right? So try to get that as much as possible. So even though it's still my go-to, it's nice to have that in my armamentarium of techniques that I'm comfortable with.
Great, thank you.
Great. And we have Dr. Forlizzi on the call now too. So just wanted to give her a chance to say hi. Dr. Forlizzi, we did do an intro to everyone at the beginning. We're just going through some questions and all panelists can answer them as well.
This is why I'm late, guys. Sorry. If anyone has, I'm sure you touched on it, questions about child rearing during residency and early attendingship, you would just come right my way. We're living it. So I'm Jules Forlizzi. My maiden name was Kowalski, if anyone knows me from Robert Wood. I got married during residency, med school residency at Robert Wood, and then fellowship at New England Baptist. So I'm sports trained. I am doing some joints. Dr. Chen, I'll see you Friday at the Striker course. I'll be there in Mawa. It's wild. I'm in a private practice that immediately trusted me to do anything and everything that I'm comfortable with. So I'm still in my boards collection, so I can speak for the early training part and the building a family part, and some sports medicine if anyone has specific questions to that. And this is Claire. She's my 3-month-old. So if you want to talk maternity leave, we can talk that too. Thanks guys for inviting me.
Yeah, I think that might be a good segue actually into talking about how to balance family with life as an orthopedic surgeon.
One of the smartest things that Dr. Hornley, who's at Robert Wood, told me was there's no such thing as a good time to have a baby. If you think, oh, I'll wait till I'm an attending because I'll be making more money and it will be financially more stable. Well, if you're in a private practice and it's an eat what you kill model, you won't be making money. And if you want to avoid it in residency, you're actually kind of a little bit more protected there. So do not worry about your training. Do not go to a residency program that intimidates you or tries to tell you when you can have a child. Focus on your partner and talk a lot early. I have the best husband in the world. He's broken down on the side of the road right now, so I was doing bedtime. But he knew the sacrifices that I had to make, and I had to take very short maternity leaves. My 2-year-old was born chief year in my chief spring, and Claire came my first year as an attending during my boards collection. So again, no good time to have a kid. Don't let anyone try to talk you into anything. It's what's right for you and your family. And there's more and more data coming out that female surgeons are delaying child rearing till later ages, needing more IVF, going into early labor. Claire came a month early. So it's something to consider and not put off. So it's something we should start talking about sooner.
So I can come to the point of Dr. Chen and I practiced together, or we went to med school together and residency, or at residency at the same time. And I waited. So I just had a kid. He's 2 months. He's downstairs screaming with my husband. But I waited because as a trauma surgeon, I didn't feel, especially in private practice, that I could have had it because I had one partner and there was no way. And then, I had to get my bearings down at Hopkins. But it's doable, and you do get maternity leave, but it's probably never going to be enough. You just have to know by law, you get 12 weeks, but it may not be paid depending on, and one of my colleagues just had a kid, and at Hopkins, if you're not here a year, you do not get paid maternity leave, but you do get 12 weeks. 10 weeks is what they allot you when you get leave. But you just have to know, but there's never going to be a good time. You have to just figure it out. And again, if you're doing it on your own, you do it on your own and figure it out. If you have a partner, you have to discuss it, and you have to have just really good childcare, because eventually you have to go back to work, and I'm going back to work in a week and a half because my kid's going to be 10 weeks.
You got this, Rachel.
It's going to be
We'll
good.
see. I'm going back day one call. Yes.
So I'm on the spectrum where I haven't had kids yet, and I do want to have kids. And there's multiple different hurdles, as already been talked about. We have occupational hazards, right? So there's been studies previously shown that PMMA is a noxious fume. It's been shown in rats to be problematic. Yes, not humans. It does not.
I did cement the whole time.
Exactly. So there's radiation, so you have to wear like super protective maternity lead, and that's super heavy. Noise pollution, bovie pollution, there's all sorts of things that can affect us as human beings, let alone vehicles for birthing children. That said, it's one of those things where it's obviously a joy and a privilege. If you have an opportunity to do so, there is no right time. I would actually say, in all honesty, the best time, if there is a right time, is a time when someone can cover your call or your cases or things like that. And that's for residency and fellowship are actually nice time frames. But we don't all have the privilege or timing to do so. But if that's something that's an option, that's something to think about if that's something that you like to have at that point in time. So instead, I have a fur baby right now. And so she's the one who keeps me going. She's a 4-pound Yorkie, don't ask. But it's one of those things where on the flip side of things, I've been able to do a lot for work-wise and, spend a lot of time traveling and doing stuff that without having a family at home. But on the flip side, now that I'm older, I'm, developing that family and things like that. And that's going to be harder. Now I'm going to cut back on some of my other requirements. So I can see some of my colleagues who are coming up behind me, their young kids are now older, so they can travel more freely now, and vice versa. There's some people who are saying, okay, now I'm starting to have kids as I'm older, I'm going to start cutting back a little bit. So it's all a matter of perspective. You can also have different practice models as well too. I know of a orthopedic surgery female who's a sports surgeon, and she decided to go part-time. Her use like, 1-day clinic, 1-day OR a week. And that's best for her and her family. And that's up to you, or you can do it. And I've seen family practice doctors work from 6 a.m. to 9 o'clock at night. So it's not just orthopedic surgery. With the knowledge of surgery, potentially you have call where you have to do cases. But your life can be as busy or as not as busy as you want, I'd say. So I don't believe in balance per se, because I don't think we're ever balanced, but prioritizing is probably the key factor.
If I may just jump in and add something that was helpful is going to the ABOS website actually has resources. So you can miss, I think, up to 6 weeks per residency academic year and still be able to sit for your written boards. And like for me, I went back at the 2-month mark with my second because I'm in my boards collection. So there's resources in the ABOS website, and the people there are surprisingly friendly, and they can answer some questions if you have child rearing questions, and times on when you can, stay on track as far as your academic career is concerned.
I would agree with all of that there really is no good time. I had one child in residency, one in fellowship, and one as an attending. I got pregnant my internship year. So I know what that looks like. I do agree that the ABOS has been more helpful in changing sort of some of the guidelines. It used to be that you could take, 6 weeks off during each year, but they didn't let you sort of aggregate them together. So now, you can sort of lump those together and miss a couple months of residency and still graduate on time. But I will say that, during my fellowship, I chose to sort of do a longer fellowship, sort of like not quite 2 years, but they were very flexible with me so that I could take time off and then come back slowly. I kind of started late, finished early, and ended up being, 18, 20-month fellowship. And I felt like I needed that to get the training that I needed, right? So you have to realize too, that you're taking time off from trying to develop a skill set. So that's super important. So, I think don't be afraid to sort of add an extra year if you need to, maybe don't sit for your boards a year if you really can't do that, those kinds of things, because you don't really get that time back with your child. I just had a partner who took 5 months maternity leave. So she had a ton of vacation time from working so long. It was her last baby. And she's like, I'll see you in 5 months. And it worked, it works. Like, we've got partners who go out to have their herniated disc repaired and their ACL reconstructed, and we should be able to go out and have, time with our child. So, I think sort of whatever everybody else thinks about you taking time off, that's the them problem. And I think it's important to focus on yourself, your education, and your family.
Thanks so much for sharing that. I had a quick follow-up question. Dr. Chen, I know you were mentioning environmental exposures, and I saw your paper come out with the increased rates of breast cancer, all-cause breast cancer for orthopedic surgeons. And I know it caused some buzz as well. So it's exciting to see. I think a lot of the general public also read that article. I was just wondering, based off of that, Do you think people will kind of adjust their practices at all during the time around that they're expecting to have a child or they're pregnant? Is that something people do, like adjust the procedures that they do?
Some will. I think few will, to be perfectly honest, because the actual exposure and the data that surrounds it is not as great. Well, I say for breast cancer, obviously men and women can both get breast cancer. The study that Jeff is talking to is women who are orthopedic surgeons have 4 times the rate of breast cancer than the general population. So one, always wear lead. I think back when I was a resident, there were times where I wouldn't wear lead just because it's hard to find, couldn't get it, it's uncomfortable, you're sleeping, you just want to get you sleepy, whatever. Always wear lead, and I make a point of it now at my OR. If anyone is not wearing lead, either to go get lead or stand behind someone who has lead or step out of the room. So if you can advocate for yourself and definitely step up and do that. The other thing too, when it comes to, for example, is cementing, which occurs in, a few areas of orthopedics. What I have some people do is, instead of cutting back of what they were doing, like now, in the past, some people would say, hey, they'll tell their colleague that they're doing that, and they'll, step out for that part of the procedure, and then the colleague would do that procedure. That's an extreme. What my other friend did was wear an N95 mask. Whenever they cracked open the vials, they put them in a bag and put them in the sharps bin and sealed it right away. To try to just reduce the amount of exposure to it, or wear a hood, things like that. So I don't think most people change their procedures. The hardest thing is, as you get along, let's say when you're carrying a baby, your abdomen is bigger, so it's harder to do certain things like potentially reduce a hip or potentially just. So I've had some of my colleagues who are hip and knee surgeons, and they would do hips early on in their pregnancy, but then switch to just knees towards the end of their pregnancy because it was easier to access. So those are practical things to think about, so that you can do some changes. Some people said actually having the baby bump was really helpful for doing scopes. They can rest the leg on their abdomen. They can use it for pressure, go back and forth. So whatever floats your boat kind of works, but some people do adjust accordingly because of pregnancy.
So I can tell you from my standpoint of just going through it, I did not change anything in my scope of practice. So I was nailing femurs actually at the end by myself in patients, and I throw them in traction on a bed anyway, supine. But I was reducing hips. I was doing pelvis and acetabulum. I wore double sets of lead from December until middle of August. So it was fun. And one day I put on the 1 set of lead, and it was quite amazing to only have 1 set of lead. But again, I only went into the room for 2 seconds to see my colleague. So, but double set of lead is heavy. I just made sure I was protected, and I cemented throughout my whole pregnancy. I just made sure I wasn't the one mixing the cement. I basically let So since COVID, I've worn an N95 every single day to work because my patients have COVID. And so I think the only case I refused to do when I was pregnant was a person who had a mycobacterium infection of their humerus with pus going down their entire humerus. And I said that I was not going to do. I was not going to put myself at risk during pregnancy. But otherwise, I did all my trauma cases, and my kid did not come early. I wanted him to. I didn't, but he didn't get the message. He likes going to the OR.
I also didn't change anything. I had pregnancy lead. I only got the skirt, the double thickness skirt, and wore a vest on top. I cemented hips, for fractures if they were over 75 or what. I did not, again, I didn't mix the cement. I'm not sure why she came a month early, but she decided to join the party a little bit early for us.
So I have a question, and then there's also some questions that were in the chat as well. I think Dr. Sotksy, you mentioned that your partner is also a trauma surgeon. I just wanted to know, how is it like being in a relationship with another surgeon? How are you guys making that work? Because I can imagine that your schedules
No,
are...
it's not my partner. No, my partner at work. So my colleague, we are the only female trauma team. My husband, unfortunately, thankfully, is not in ortho. And he says, thankfully, he's not in ortho. He's in a field called politics, which is possibly worse.
So, does anyone in the crowd, is anyone married to someone in medicine? I'm only asking because my girlfriend is also applying to med school, and I kind of like going down the line. I don't know what she wants to do, but I wanted to get some advice on how to make that work, I guess.
So I personally am not in that same category either, but I have a bunch of colleagues who are. So we have at least 3 couples of orthopedic surgeons who are with other orthopedic surgeons, which is a very high percentage for some strange reason. One of the things that's actually probably pretty helpful is the fact that you guys are not at the same year. I think being the same year is a little bit harder. Staggered can be good or bad, right? So couples match is one of the things I think that was difficult. One of my colleagues, she's a sports medicine surgeon. Her husband's a joint replacement surgeon. He had military obligations in the Army. And so she actually did her residency out in Hawaii because that's where he was stationed. So she made an effort to go out there. He was before her. So he went to med school, and I think in Tulane, she went and joined him down in Tulane. And then he went out to Hawaii where he was stationed. She went out there for residency. They went to different places for fellowship. It's only 1 year, and then ended up in the same place. They're 2 different hospitals. So one's my hospital here, one's hospital there. And the nice thing about it is that they just have to stagger things like call, right? So one of my other colleagues is a tumor surgeon, and his wife is a sports medicine surgeon. So they can't take call at the same time, because if they do, then there's no one to take care of their kid. So that's one thing to think of as a logistics standpoint. The hardest part is then you don't get a crossover, and like ideally you would take call on the same weekend. And if you do that, then you get it knocked out of the way, and then you can spend other weekends together. So that's one of the areas that you have to balance. Training where you do that and when you do it and how you do it is going to be something that's more difficult, but you just have to be really smart about your time. So, some of the advice that I've heard from my friends, regardless if your significant other is in medicine or not, is that when you have time together, it's precious. So don't spend that time necessarily doing like chores or tasks or errands, you know what I mean? Like you have to take care of your child. If you have children, that's one thing. But if you can outsource things like, someone cleaning your house, as much as I like cleaning my house and it's therapeutic and cathartic, there's only so many hours in a day, and you can't spend that time with someone else if you're doing those things. So medicine, just to be intentional about it and trying to time when people are finishing it. Like I know of people who, one of my fellows back when I was at Rothman, her significant other was going to go into fellowship. She was finishing residency a year before. So she worked for a year as a general orthopedic surgeon before doing fellowship at the same time he was. And then they both went into practice together. So that's what people, I'm just using examples of people who are all in orthopedics. That's not necessarily the case, obviously. But there's plenty of people who are married to other people in medicine. And you just have to juggle things and make sure that you take both of your interests into consideration. Right. So if you're, academically minded and you want to go into and travel into a lot of meetings and things like that, be sure to take the other person into consideration. One of my colleagues across town, he's a spine tumor surgeon, and his wife is a general surgeon. And so for a period of time, it was about his career. And now the flip side, it's now about her career. And now they're moving to LA because it's her career. She's going to be chair of general surgery. So take turns, value each other, obviously, and make sure that you both feel that you're both being represented in your relationships.
Great, thank you.
So on that note, so both my aunts and uncles are all doctors, and they've been at work over the years and had 3 and 4 kids each. And then my colleague right now, she's an ortho trauma surgeon. Her husband is a Maryland resident. He's in his chief year, so he's 3 years behind her. He's going to fellowship next year. So the way they made it work is they were at Rothman together for med school. She left, went to residency. He then matched in a program that was close enough. They lived in between in Maryland. She was at GW. He's at Maryland. They lived in between. Then she went to fellowship for the year by herself. She then.
I think you might have cut out a little bit.
Can you hear me now?
Yes.
And then he's going to go to Penn next year to do his shoulder and elbow. So it at work, and then they're trying to get either him to come to Baltimore, or they're trying to find a job together so that they're together when they're attendings, but just make it work. They've lived in between. As residents, they both commuted so that they could live together. So you just figure it out. And as Dr. Chen said, one partner takes the lead at a time. And, it means a lot of times making sure you're not on call at the same time when you have kids, or if you are on call, you have live-in care.
Great, thank you. I think we should, Amy, feel free to ask your question.
What was it like, what's it like going into a male dominated field?
I can start us off there. In arthroplasty, it's 2.6% women, thankfully climbing, but we're probably the slowest compared to, or we're on par with spine. So spine and arthroplasty are the two lowest when it comes to women in the field. So I will say that whenever I go to a meeting, there's no line for the bathroom, and it's a glorious thing. That said, on the flip side of things, it really depends on who you work with. You know, there's some areas and some surgeons that you'll work with who, whether they verbalize it or not, don't think necessarily women should be in the field. And not that they'll make you uncomfortable per se, but they may not be as supportive, right? On the flip side of things, there are other people, and some of my greatest mentors are men, right? So it doesn't necessarily mean male or female, but it is a little bit interesting when, I go for I did a traveling fellowship, and I was like, okay, I'm going to go to the women's locker room to change. They're like, we have no idea where that is. So the guys all go to the locker room and hang on, they're talking, and then you're kind of left behind in a separate area. So it's a little bit hard in that, like, you may not be necessarily automatically included in things just because of gender, because of things like, separate locker rooms. But that said, I think the field is changing and it's becoming more inclusive over time. And I think, and other people can chime in here, is becoming more gender blind. It's not yet gender blind, but it is becoming more gender blind.
I have to agree with Dr. Chen. So when we went to residency, and especially when I was a resident, it was not gender blind. And, I had, as a med student and as a resident, I had comments, and you just had to have really thick skin. I think things have definitely changed. I noticed that with the residents that I train now, and it's more gender blind, and we're more inclusive. There are more females. I had Dr. Harnley was only resident before me. I was the 4th female resident in the Robert Wood history in 30 years. And then Dr. Balicka, who is one of the pediatric cancer surgeons, she was the only time there were 2 women at once. So, and actually when I matched, the joke was shower curtain because there's a girl coming and she's going to buy smelly spray for the bathroom so that our call room smells nice. And at the time we had 1 call room for myself and all the guys. So, I think things have changed. But even when I started being an attendant in private practice, a lot of the places did not have a women's surgeon's locker room. Women share the locker room with the nurses. Men had their own attending locker room. Now at Hopkins, it's men and women locker rooms. But when I was in private practice, I shared the nurses, while men had an attending's locker room versus staff locker room. So, very, very different. And, just what you say to people doesn't fly like it did, or like it shouldn't have in the past. So things have definitely changed. But it's still not gender blind. And, I'll echo that, it's great going to a conference because there's no line at the bathroom. And also when you go take part 2 of your boards, and you have to take your oral boards, and when they tell you right before you go in, you can go to the bathroom, and the guys have to think about it. And as a female, you don't, because there's no line.
Yeah, I would agree that it's definitely gotten better. It was, I don't know if I'm the oldest attending here, but it was a little rough in the beginning. Not necessarily in the treatment towards me, but sort of in the culture that was just accepted, right? And the talk and the discussion and the slang and the conversations were, quite raunchy a lot of the time. And I agree. I just had a thick skin. It didn't bother me that much. I do think that the meetings are still problematic. I mean, you go to these meetings and it's really, you're really a minority there. And then there's, dinners and drinking. And then I find that the boys start behaving a little badly. So, I just don't go to them that often. Or if I do, it's, okay, we're going to go out to dinner and then I'm out, I'm not interested in whatever's happening after that. So that can be a little bit, I think we still have a lot of work to do in some places like that. But I do think that, the Academy is, and many programs are very interested in improving their diversity and having women. And, I think that because that message is being talked about, that for the residents, it's almost second nature. So they also want that. And so there's a real effort to make people feel included. And you'll find, your mentors sort of all over the place, and other men, and, in male nurses, there'll be all sorts of people that will really support you along the way. So I kind of feel like it's having, older brothers and younger brothers, really. And that's sort of the environment you're in. And sometimes they're going to behave badly. And, I do find that if you just say that was the line and you just crossed it, that it doesn't really ever happen again. So there are nice ways to sort of, point out the bad behavior, and sort of stop it in its tracks.
And one thing I can add to that term that I've learned recently is instead of a bystander, it's an upstander, right? So as a medical student, resident, fellow, even early attending, I didn't feel very comfortable speaking up for myself. It becomes a little bit more comfortable, but once you're in practice for a little bit of time, you kind of care a little bit less about that. So for those here on this call, you may not need to speak up because there can be retaliation to that. And we know that can be really problematic, but go to someone else in confidence and have them upstand for you, so I've upstanded for, individuals, not just females, but, for various reasons, there's race considerations, race ethnicity considerations, gender considerations, all sorts of considerations where people will say insensitive comments. And it may not be from orthopedic surgeons, it can be from staff, it can be from other things. And you have advocates who can speak up for you. So you don't have to say it yourself, you can have others do it as well.
Rachel, I can tell you nothing changed from when you and Deidre were there to when Aaron and I were there. 0% change. But that being said,
are the call rooms cleaner?
Only because they moved it 3 times through the construction. It was freaking terrible.
Is the box still there? In the bathroom?
No, they moved the bathroom. Thank God.
They don't have the cat. Was it the Kathy Ireland poster, or was it Cindy Crawford?
Thank goodness.
That got taken down my intern year, and I'm only my second year in practice now. So not that long ago.
There when Jaco walked into the call room, and there was pretty raunchy photos, and I was on call, and they were like, "What is that?" And I was like,
Right.
"I'm like, I don't know, gotta go."
Yeah. That being said, I think Dr. Harley, Dr. Sotksy, Dr. Belika, and everyone here has done a lot of the work for me. So when I walked in, and I'm also a jock. I went into sports med. I'm like 6 foot. I'm over 6 foot tall. I'm more athletic than most of my male counterparts. So just walking into the call room, they didn't have a lot to say to me. I did race one of the other male residents after anatomy lab one day to kind of prove our athletic prowess. But you can have fun with it. You can choose to let things get to you. But now that it's 2022, people realize when they say something stupid, and they'll like look at you and be like, "Oh, I shouldn't have said that." And I just nod like, "Yeah, you shouldn't have said that." And I'll just let it go. For example, a 5-year-old came in recently with a type 2 supracondylar, and we have a surgery center, and I feel comfortable pitting supracondylars. Fine. So at the end of this 25-minute discussion with the patient's mother from a very wealthy suburb of New York City, she said, "Okay, so who's the surgeon going to be?" And I was like, this hurts because we are close to the same age. You have a 5-year-old, I have toddlers. And I just spent all this time explaining to you how I'm going to do the surgery. And because I'm a woman, definitely that's why you asked who the surgeon was going to be. But the next morning when, I met her kid, she apologized. And I think that takes a really big person to be like, "Listen, I'm really sorry. I was flustered because it's my kid." So I haven't really gotten it from my partners. Again, they're more like, "Oh, you're definitely one of the more athletic people in our 10-man practice, the only woman." But it comes from patients too, and that'll shock you every once in a while, especially younger patients,
Yeah, it comes from my patients a lot even post-op. And I talk to my trauma patients in the holding area or on the floor, and then or I've had, when I was in Northern Jersey, my uncles and aunts are all physicians up there. And I had a patient once tell me, as I was wheeling them from the ER into the OR, "Well, Dr. Sotksy is a male." And I was like, "Well, no, they're not." So, but like Julie, I was a jock. And so the guys didn't give me problems because as a med student, they used to run from anatomy. So they used to run from the hospital over to the anatomy lab at Robert Wood. And the day that I ran with them. They all decided not to run because I beat them. And so I beat Rob Masella, was the only resident who would run with me, and he got hosed big time. And I was talking and running, and he was like down the street, and I was trying to figure out why he's going back and forth on hose lane. And it's because he was dying and his IT band was killing him. So he had to switch sides to get the unlevel ground on the other side of his leg. So you just have to show him.
On the flip side of things, I like athletic activities, but I'm not athletic as these two girls. So it's okay to not be super athletic and still get along with them. So just throwing it out there. But I will say, actually, in my residency, I had I had 3 other females in my class, and that was a lot out of 8. So there are more and more women entering the field. So just strength in numbers is a big thing.
Yeah, I will agree with, somebody put in the chat, how did you find the confidence? And I also am a runner. So I think that you have a lot of confidence when you can outrun the guys. So, and there are studies showing that many of the women that come into orthopedics do so because they were introduced to a sport. They played a sport in high school, they played a sport in college, they played a sport afterwards. So, all sort of thanks to Title IX and our ability to be able to participate in sports, earlier on and continue that. But I do think there comes a lot of confidence with being able to, participate in a sport. And even sometimes if you're in a co-ed sport, right, like running can be co-ed, I think you sort of learn to be in that space with people that are the same gender as you, and can really feel a little bit more comfortable, so that you don't feel so uncomfortable when you're, suddenly in a field with all men. And we have a very unathletic bunch of residents too. So I'm gonna have to add that. Like, I don't know what is going on, but like.
Thank you.
Hi, everyone. So kind of in the same vein, I just wanted to ask sort of like, since we're talking about like confidence and getting involved once you're already at this level of like either in residency or beyond in orthopedics. I know that there are some challenges to like women when you are approaching, whether it's like rotations or away rotations in orthopedics and like all these other extracurricular activities like clinic and whatever. Is there anything in your experience or in your opinion that you think female students who are interested in orthopedics can do to sort of set themselves apart and be taken a little bit more seriously as you are trying to gain more exposure to orthopedics? Or have like just any advice about that would be really appreciated.
I think the biggest thing for me is not to have a chip on your shoulder. If you, for whatever reason, if you've experienced something or something like that, my goal is to choose the best students, for lack of a better term, right? So if you show that you're interested, you have knowledge of anatomy, you stay late, you come early, you really help the team, you're not overeager, then I don't mind if you're green, orange, purple, male or female. I'm going to really like you, and that's kind of one of the best things I think is come in because you love ortho. Come in because you love what you're doing, not just because of your gender, I would say. But to your fair, there are going to be times that these women have talked about, examples where people will be joking or, say things that you may not feel as comfortable with. And again, that's something you can tell someone else to do. But for a woman to stand out, I feel like, I don't know how the women feel on this panel, but we have to work twice as hard as our male colleagues sometimes. So work really hard, be available, and be good at what you do. And then I think gender matters less than, and that you're just a really good person that they want to be with.
I tell all my rotators, just do the work hard. Be part of the team. It doesn't matter who you are, male, female, red, black, purple, green, whatever. Just know where your stance is, know how to help the team, bring your dressings along. I always say, like, in your white coat, have 500 pieces of gauze and have the tape, have your trauma shears on you, make sure you're helpful to the residents. And, that's what makes you a good resident, or that makes you a good medical student, whoever you are. So, if you're a hard worker, that's how you're known. It doesn't matter if you're male, female, or anything.
Awesome. Thank you.
Hi,
Great.
I have a question.
Go ahead.
Thank you so much for coming in today. I don't know if this was already answered, but how would you recommend as students who are interested in surgery when it comes to making connections with outside institutions?
Yeah, I think that can be tough, depending on what your schedule looks like. I think, summer between first and second year is a good opportunity for you to apply to programs where you can do research at other institutions. If there's opportunities to shadow other surgeons, on holiday breaks and things like that, that's one way. And certainly, connecting maybe with other ortho interest groups and if they have virtual sessions, things like that. I mean, I try to, as much as I can, have the women in orthopedics that are, interested in orthopedics at New Jersey Med School and Rutgers connect with the women who are interested in orthopedics at Robert Wood Johnson, Rutgers, right? So, we're only 45 minutes apart. We can have these kind of Zoom meetings and invite people from both sides, right? So that you're, instead of duplicating opportunities, you're just adding more people to the opportunities that already exist. But I think it can be really challenging unless you sort of make a commitment to go to another institution for a solid period of time.
Yeah, and I'll echo that as well too. One of the things is I get people who reach out all the time, which is fantastic. If you can't be in person and you can only work remotely, one, our research department actually doesn't allow you to do that anymore. We used to be able to work with students remotely and give them Epic access remotely. They've stopped that now since COVID is over. So whatever that means. When you have letter writers as well, you want letter writers to write about your research experience and your clinical experience. Those are the strongest letters, not just your research experience. So if you want to connect with an outside institution, that's great. The best way to do so is to do a year-long research timing with them. And that way you can, my current research fellow right now, he didn't match. So he's taking a year off to do research and he comes into the OR once a week. And so it's great because I get to see him in the OR and I get to see him do research. And so my letter for him is much stronger that way. So that's the best way to do it. If you can spend a year dedicated time with them. If you can't spend that much time, which is totally understandable, a summer's ideal, or whatever it is, if you can connect with them and then spend some time shadowing, if you have to do your away elective there, now which is not till later, but that's actually very helpful.
Thank you.
Great. So we're going to conclude the evening. I know it's a little bit after 7, so after 8, sorry. So we just wanted to thank everyone for your time today. We really appreciate you coming on the call and speaking for our students and helping them explore the field. So we really appreciate it.
Thanks for organizing.
Thank you, everyone. And thanks to all the NJMS students who also signed on tonight.
Thank you.
Have a good night.
Thanks. Bye, guys.
Thank you.